You know that feeling when you're just, I don't know, uncomfortably full? Like maybe something extra is going on in your abdomen.
Mm,
Today, we're diving into exactly that. There's a condition called ascites, and it's essentially a fluid buildup right there in the abdominal cavity.
exactly. Yeah, we're going to unpack what ascites actually is, what might cause it, how doctors or vets figure it out, and, how it's managed.
Okay.
We've got some pretty detailed medical info here, and, well, the goal is really to pull out the crucial bits for you, explain the mechanisms behind it without, hopefully, drowning you in jargon.
Right, trying to find those aha moments, connect some dots.
Precisely.
Okay, so let's start with the basics then. What is ascites, fundamentally?
Well, at its simplest, it's when fluid basically escapes and starts collecting in that space
Hmm.
between the abdominal lining and the organs themselves, between the parietal and visceral peritoneum.
Okay, the membranes.
Right. And what's really interesting is that this fluid isn't all the same. We generally talk about two main types,
Yeah.
transudate and exudate.
Transidate and exudate. Okay, those sound important. What's the key difference we need to grasp there?
So think of transudate as like a thinner, more watery fluid. It often happens because of pressure issues like imbalances or maybe low protein levels in the blood. That causes fluid to sort of leak out of blood vessels.
Okay, leaky.
Yeah. Exudate, on the other hand, it's generally thicker. It's usually a sign of something like inflammation or maybe an infection. This fluid is richer in proteins and cells.
So one's more about pressure and protein, the other's more inflammation or infection.
That's the core idea. Yeah. Pressure imbalances, low protein often lead to that watery transudate.
Mm.
Inflammation, infection, you get the protein, and cell-rich exudate.
That makes sense. So it's not just, random liquid sloshing around. What are some of the actual reasons this fluid starts accumulating where it really shouldn't?
Oh, there's a pretty wide range of things that can cause it.
Yeah.
One major area is heart issues, specifically congestive heart failure, particularly right-sided. When the heart isn't pumping blood back effectively, it interferes with the blood returning through the veins. This can, crank up the pressure in those veins, leading to fluid leaking out.
Like a traffic jam backing things up.
That's a really good analogy, yeah. A circulatory traffic jam causing a fluid spill in the abdomen.
Okay, vivid. What else can go wrong?
Well, another big factor is having too little protein in the blood. Hypoproteinemia.
Right.
This might happen if the body's losing protein where it shouldn't, maybe through the kidneys, that's called protein-losing nephropathy,
Hmm.
or maybe through the gut, protein-losing enteropathy. Low protein levels reduce what's called oncotic pressure in the blood.
Oncotic pressure, like those sponges you mentioned earlier.
Exactly. Think of protein, especially albumin, like tiny sponges in your blood vessels, helping hold on to water. If you don't have enough sponges, the water can just leak out into tissues, into cavities like the abdomen.
Okay, that analogy really helps clarify it. What other kinds of issues can lead to ascites?
Blockages. They could definitely be culprits. So if the vena cava, that's the main vein bringing blood back to the heart, or the portal vein, which carries blood from the gut to the liver, gets blocked somehow.
Pressure builds up again.
Right. Pressure builds, fluid leaks. Similarly, you have the lymphatic system in the abdomen. Its job is to drain fluid. If that gets obstructed, maybe by cancer, it can't do its job, fluid backs up.
Wow.
And sometimes with certain abdominal cancers, the tumor itself can just directly produce fluid. A neoplastic effusion.
So blockages, leaky pipes from pressure, not enough protein sponges? It's starting to connect. What about infections inside the abdomen?
Yes, absolutely. Infections or inflammation there, generally called peritonitis, that can also cause fluid to leak into the cavity. It's usually that exudate type we talked about.
Okay.
Also, electrolyte imbalances, particularly high sodium hypernatremia, might contribute sometimes. And a really, really common cause, especially in people, is liver cirrhosis.
Ah, the liver.
Yeah, the scarring in the liver just not working right. That leads to increased pressure in that portal vein we mentioned, and other issues causing fluid buildup.
Honestly, liver problems and heart failure are probably two of the most common drivers we see.
It really underscores how ascites isn't really the disease itself, but more of a sign, isn't it? A signal that something else major is going on.
That's a perfect way to put it. It's a clinical sign.
So which body systems end up getting affected most by all this extra fluid hanging around?
Well, because the abdomen houses so many vital organs, the impact can be pretty widespread. We're definitely talking the cardiovascular system, like with heart failure.
Right.
The gastrointestinal system is obviously directly affected by the fluid just being there, pressing on things. The hemic, lymphatic, immune systems, they can be involved, especially if it's infection or cancer causing it.
Mm-hmm.
And the kidneys, the whole renal and urologic system, they're often involved too, especially fluid balance regulation and maybe protein loss.
Right.
So yeah, it touches on a lot of different areas. And it's not just a human thing, right? I think you mentioned dogs and cats.
It is, absolutely.
Yeah.
Ascites happens in dogs and cats too. And interestingly, the sources we looked at suggest there isn't really a specific breed that's more likely to get it than others.
Okay, good to know. So, shifting gears a bit, what are some of the things someone might actually notice? What are the signs that might make you suspect ascites is developing?
The signs can definitely vary, depending on how much fluid is there and how quickly it built up. But some common things include maybe periods of weakness or just general lack of energy, lethargy.
Okay.
Obviously, a key sign is that feeling of fullness or bloating in the abdomen. The belly might look visibly swollen, distended, maybe even feel a bit firm or uncomfortable to the touch.
Makes sense.
If there's a lot of fluid, it can actually press up on the diaphragm.
Making it hard to breathe.
Exactly. Difficulty breathing, shortness of breath. You might also see a loss of appetite, maybe some vomiting. And oddly enough, sometimes weight gain, even if they're not eating well, just from the weight of the fluid itself.
Wow.
In some cases, you might even see swelling in the scrotum or penis. And some people or animals might even groan when they lie down, just from that internal pressure and discomfort.
Those are definitely signs that would make you worried. So when doctors or vets are trying to figure out the why behind the ascites, what specific conditions are usually top of the list?
Well, our sources highlight several key ones. We've touched on some already, like nephrotic syndrome, the kidney protein loss one.
Right.
Liver cirrhosis, definitely. Right-sided congestive heart failure. Hypoproteinemia, just low protein in general, whatever the cause.
Okay.
But also things like a ruptured bladder, believe it or not. Peritonitis, that abdominal infection. Abdominal cancer for sure. And even active bleeding within the abdomen, hemorrhage.
So quite a few serious possibilities. It sounds like the first step, if ascites is suspected, might be ruling out other things that make the belly look swollen but aren't actually fluid buildup.
That's a crucial part of the diagnostic process, yeah. It's called differential diagnosis. You have to consider the lookalikes.
So what are some of those?
Things like just organ enlargement. Maybe the liver is huge, hepatomegaly, or the splenomegaly, or the kidneys.
Okay.
Or maybe the uterus is filled with fluid. Hydrometra. Actual abdominal tumors, masses, can cause swelling. Pregnancy, obviously.
Right.
Even just a severely full bladder that hasn't been emptied. Or being significantly overweight, obesity. And there's a condition, mostly in dogs, where the stomach fills with gas and twists gastric dilatation volvulus, or GDV, that causes massive abdominal distension.
Okay, so a swollen belly definitely doesn't automatically equal ascites.
Yeah.
Now let's circle back to those two fluid types, transudate and exudate. How does figuring out which type is present actually help narrow down the cause?
It's hugely helpful.
Yeah.
The characteristics of the fluid itself give you really valuable clues. Like we said, transudate, low protein, low cells, that often points towards conditions where there's a body-weight pressure issue or just not enough protein.
So like the heart failure, the liver cirrhosis, the kidney protein loss.
Yeah, exactly. Nephrotic syndrome, cirrhosis, right-sided CHF, general hypoproteinemia, and even a ruptured bladder can initially present with a transudate-like fluid.
Okay. And the exudate.
Exudate, with its higher protein and cell count, suggests something more localized is going on, usually inflammation or infection. So that points you towards things like peritonitis, abdominal cancer, or internal hemorrhage. The fluid itself tells a story.
It really is like being a fluid detective. What about the routine stuff? Blood tests, urine samples, can they add pieces to the puzzle?
Absolutely. Standard blood work and urinalysis can provide a ton of insights. For instance, if you see a high white blood cell count, especially neutrophils, that might suggest a systemic infection somewhere.
Okay.
Low levels of albumin, that main blood protein, that points towards maybe the liver not making enough or protein being lost via the gut or those leaky kidneys again.
Right.
Low cholesterol, interestingly, can sometimes also hint at poor liver function. Basically, you're looking for patterns. Low protein suggests liver, gut, or kidney issues. High white cells point towards infection.
And what about liver enzymes? We hear about those a lot.
Yeah, liver enzyme levels are really informative. Sometimes low to normal levels might actually be seen if the liver is failing and just can't produce enough proteins like albumin.
Oh, okay.
But high levels often mean the liver is inflamed, hepatitis, or maybe there's a blockage stopping bile flow, cholestasis, or even just chronic congestion because of heart failure, backing things up into the liver.
Makes sense.
And bilirubin levels that substance the liver processes can also help. Comparing total bilirubin to the direct form can help figure out if the problem is the liver's ability to process it, or if there's a physical blockage in the bile ducts somewhere downstream.
Okay, so lots of clues hiding in the blood work. What about checking kidney function?
Yep. BUN, blood urea nitrogen, and creatinine levels are your main go-to markers for kidney function. High levels usually mean the kidneys aren't filtering waste properly.
You said BUN can be low with liver issues.
Yeah, that's an interesting twist, because the liver makes urea. Really severe liver disease can sometimes lead to lower than expected BUN. And glucose levels can offer hints too. Sometimes low blood sugar might be seen if the liver function is really impaired.
So it's like assembling a big picture from all these different tests. Are there any more sort of specialized lab tests that might get used?
Yes, definitely. Depending on what those initial results show, you might dig deeper. If protein levels are really low, a test called protein electrophoresis can break down the different types of proteins, and an immune profile might look for specific immune issues.
Okay.
To quantify how much protein is being lost in the urine, there's the urine protein dot creatinine ratio, or UPC. That's a really important one for kidney disease. And specifically for liver-related ascites, especially suspected cirrhosis, there's a calculation called the SAG, the serum ascites albumin gradient. You compare the albumin level in the blood to the albumin level in the acidic fluid.
And that tells you...
It helps determine if the ascites is likely due to high pressure in the liver's portal vein system, which is really common in cirrhosis. A high gradient points towards that portal hypertension.
Wow. Okay. That's quite a detailed lab investigation. Beyond the labs, what about imaging, like x-rays or ultrasounds? How do they fit in?
Imaging is often absolutely critical. Simple x-rays, chest and abdomen can sometimes give you useful information, maybe show generalized fluid haze or organ displacement.
But ultrasound is key.
Ultrasound is usually the star player here, yes.
Yeah.
It lets us look directly at the liver, spleen, kidneys, bladder, pancreas, the whole abdomen, really in real-time detail. It's fantastic for confirming, yes, there's fluid here, and often, more importantly, it can help pinpoint the cause.
How so?
Well, you can see if organs look abnormal, if there are masses or tumors, if the liver texture looks cirrhotic, if there are signs of heart failure affecting the liver vessels, if the bladder looks intact. It gives you a direct look inside.
Right, okay. So let's say we've confirmed there's fluid, maybe with ultrasound. How do doctors or vets sort of grade how bad it is? Are there different stages?
Yes. Ascites is often categorized into 3 stages. It helps understand the severity and guide management.
Okay.
Stage 1 is minimal ascites. You might only be able to detect it with imaging, like that ultrasound. It's not obvious otherwise.
Sure.
Stage 2 is moderate ascites. Now, the abdominal swelling, the distension, is becoming noticeable visually, or you can definitely feel the fluid wave during a physical exam.
And stage 3?
Stage 3 is significant, or sometimes called tense ascites. You've got marked abdominal distension. The patient is usually quite uncomfortable at this point, and like we mentioned, might be having trouble breathing because of the pressure on the diaphragm.
Okay, so from just a tiny bit seen on a scan to a whole lot causing real problems. Once fluid's confirmed, it seems logical the next step is often to actually get a sample of it, right? To analyze it. How's that done?
Exactly. That fluid analysis is key. The procedure is called abdominocentesis or paracentesis. It involves carefully, and under sterile conditions, inserting a needle into the abdominal cavity to withdraw a small sample of that fluid. Usually just a few milliliters is enough for testing.
And that goes off to the lab.
Yep. It goes for various analyses, looking at the color and clarity, measuring protein and specific gravity, counting the cells, and looking at what types of cells are present under a microscope, that's cytology. And if infection is suspected, sending some for bacterial culture and sensitivity testing is crucial.
And this is where we really drill down into whether it's transidate, exudate, or something else entirely, right? What are the key things they look for?
Absolutely. Let's break it down. For a pure transidate, like we said, think low protein, low cells. It's typically clear, maybe colorless or pale yellow. Protein is low, usually less than 2.5 grams per deciliter. Specific gravity is low, less than 1.018. And the cell count is low, generally under 1,000 cells per cubic millimeter, mostly those mesothelial lining cells and maybe some neutrophils.
Okay. What about a modified transudate? You mentioned that earlier.
Right, modified transudate is kind of that middle ground. It might look a bit reddish or pinkish, maybe slightly cloudy. Protein is higher, in the range of 2.5 to 5 GDL. Specific gravity is higher too, usually above 1.018. And the cell count is a bit higher, maybe up to 5,000 cells on millimeter 3, with more of a mix of neutrophils, mesothelial cells, maybe some red blood cells and lymphocytes, often seen with things like right-sided heart failure or some tumors.
Got it. Now let's tackle exudate, the stuff linked to inflammation or infection. What are its telltale signs? Let's start with non-septic.
Okay, non-septic exudate, meaning inflammation is there, but we haven't confirmed bacteria yet. This fluid often looks pink or even white, and it's usually cloudy. Protein is similar to modified transudate, maybe 2.5 to 5 GDL, or sometimes higher. Specific gravity is usually over 1.018, but the cell count is significantly higher, typically ranging from 5,000 up to maybe 50,000 cells a millimeter 3. Again, a mix of cells, but often more neutrophils. You see this with non-infectious peritonitis of some cancers.
And the really bad stuff, septic exudate.
Yeah, septic exudate means active infection. This fluid can look really nasty, red, white, maybe yellow, and it's definitely cloudy, maybe even turbid. Protein is usually high, often over 4.0 GDL. Specific gravity is high, over 1.018. And the cell count is way up there, anywhere from 5,000 to over 100,000 cells in DNA. And crucially, it's packed mostly with neutrophils, often degenerate ones, and you can usually see bacteria under the microscope or grow them in culture. That's a surgical emergency often.
Okay, seeing bacteria is the smoking gun there. What if the fluid is just obviously red, like blood?
That points strongly towards hemorrhage or active bleeding into the abdomen, hemoabdomen. The fluid will look red. If you spin it down in a centrifuge, the liquid on top, supernatant, should ideally be clear. We get a big red button in the cells at the bottom. Proteins are high, usually over 5.5 GDL, like blood. Specific gravity varies. The cell count looks like peripheral blood. And a key identifier, true hemorrhage fluid usually doesn't clot in the collection tube because the clotting factors have already been used up inside the body.
That's a useful tip. Okay, we've all heard of chyle. What does that look like if it's leaking into the abdomen?
Ah, chyle. That's lymphatic fluid rich in fat. It's quite distinctive. It often looks milky white, but can also be pinkish or straw-colored, depending on diet and if there's blood mixed in. Protein is moderate to high, maybe 2.5 to 7 GDL. Specific gravity varies widely. The cell count is usually moderate, less than 10,000 cells a millimeter 3. But the key is it's predominantly small lymphocytes, those immune cells from the lymph.
And isn't there a simple test for chyle?
There is. Two things. One, if you refrigerate true chyle, it often separates, forming a creamy layer on top because of the fat. Two, it stains positive for fat droplets with a special stain called Sudan III.
Incredible. Just putting it in the fridge can tell you that much. Are there lookalikes for chyle?
Yes, there's something called pseudochyle. It also looks white or milky and can have similar protein, specific gravity, and cell counts, often with lymphocytes. The big difference, pseudochyle does not separate into that creamy layer when refrigerated, and it does not stain positive with Sudan III because the cloudiness isn't due to fat, but maybe cells or debris. It's seen with some chronic conditions or tumors.
That's a really neat distinction. What about a ruptured bladder? If urine is leaking in?
Urine in the abdomen, uroabdomen. The fluid itself is often clear to pale yellow, maybe slightly cloudy. Protein can be high, over 2.5 GDL. Specific gravity is variable. Cell counts can range from moderate to high, often with inflammation. Now, here's that interesting timing thing. If the rupture happened very recently, say less than 12 hours ago, tests for glucose and protein in the abdominal fluid sample might actually be negative.
Why is that?
Because the urine hasn't had enough time to fully equilibrate or cause significant inflammation yet. But if it's been longer, then yes, you'll typically find glucose and protein. A definitive test is comparing creatinine levels in the fluid versus the blood tire. The fluid creatinine will be much higher if it's urine.
That timing detail is fascinating. Okay, one last one. What if it's bile, like from a gallbladder rupture?
Bile peritonitis. The fluid often looks slightly cloudy and has a distinct yellow or greenish tinge. Protein is high, over 2.5 GDL. Specific gravity is up, over 1.018. Cell count is usually high, showing inflammation, sometimes very high. The key diagnostic clue here is finding bilirubin in the abdominal fluid. You could often detect it using a simple urine dipstick on the fluid sample, even if the patient doesn't look jaundiced overall. This confirms a leak from the biliary system, gallbladder, bile ducts, or sometimes the upper intestine.
It is just amazing how much information is packed into that fluid sample. So, okay, they've done the detective work, analyzed the fluid, maybe done imaging in labs, and have a good idea of the cause. What are the general strategies for actually treating the ascites?
Right, treatment really hinges on two things: the underlying cause, first and foremost, and the patient's overall condition and how badly the fluid is affecting them.
Okay.
Sometimes, if it's mild and the patient is stable, it might be managed on an outpatient basis with medications and monitoring. But if it's severe, causing breathing problems, or due to something needing urgent intervention like septic peritonitis, then hospitalization is definitely needed.
And if the fluid itself is causing problems, like making it hard to breathe.
Then a primary goal is often therapeutic abdominocentesis, removing enough fluid to make the patient more comfortable and improve breathing. You don't necessarily have to remove all of it, just enough to relieve that pressure.
And diet plays a role sometimes. You mentioned salt restriction.
Yes, especially for sites caused by transidates, so related to heart failure, liver cirrhosis, or low-protein conditions. Restricting dietary sodium is often a cornerstone of management to help reduce overall fluid retention.
Makes sense. What about for exudate?
For exudate, the main focus has to be treating that underlying cause. If it's septic peritonitis, that often means surgery to clean out the abdomen and fix the source, plus aggressive antibiotics. If it's inflammation or cancer, treatment targets that specific process.
Okay. What about those stage 3 cases with a huge amount of fluid? Is there a specific procedure for draining a lot of it?
Yes, that's called large volume paracentesis, LVP. It's typically reserved for that stage 3, tense ascites, where the volume is causing significant distress.
And how does that work?
Often, before starting, the patient might get intravenous fluids containing something called colloids, like hetastarch or plasma. This helps to kind of prop up the blood volume because removing a large amount of fluid quickly can sometimes cause blood pressure to drop.
Oh, okay.
Then a catheter or a needle is placed and fluid is drained off, sometimes several liters, until the flow slows down or the patient is comfortable. They might get more colloid fluids afterwards, too, to maintain stability.
Got it. Are there specific medications commonly used to help manage the fluid buildup long-term, especially for those common causes like liver or heart failure?
Absolutely.
Mm.
For ascites due to liver disease or congestive heart failure, the tag team is usually sodium restriction plus diuretics.
The water pills.
Exactly. They help the kidneys excrete more sodium and water. A common first-line approach involves diuretics like spironolactone, often combined with another one like hydrochlorothiazide, HCTZ.
Okay.
Spironolactone is particularly useful because it helps counteract some hormonal changes seen in liver disease and also helps conserve potassium. If that combination isn't quite enough, sometimes a more potent loop diuretic like furosemide might be swapped in for the HCTZ. But usually, the spironolactone is continued.
And monitoring is key with those.
Oh, absolutely crucial. You have to keep a close eye on electrolytes, especially potassium levels, because diuretics can throw them off balance. Kidney function, BUN, creatinine, also needs regular checks.
What about for ascites due to low protein or kidney issues?
A similar diuretic approach might be used, often starting with spironolactone and maybe adding furosemide. But sometimes, particularly if protein levels are very low, giving those intravenous colloid solutions like hetastarch intermittently can also help.
How does that help?
Hetastarch temporarily increases that oncotic pressure. Remember the sponges in the bloodstream, helping to pull some of the fluid from the abdomen back into the circulation so the kidneys might have a better chance of excreting it, especially when combined with diuretics.
Okay. And for septic exudate?
That's all about antibiotics. Broad spectrum initially, then tailored based on the culture and sensitivity results from the fluid analysis. And often surgery is needed too.
So it really is a tailored approach. Once things are under control, what about ongoing management? Keeping the fluid from just coming right back?
Yeah, ongoing management is critical. And again, totally depends on the underlying cause that's being treated. Regular monitoring is key.
What kind of monitoring?
If diuretics are part of the plan, that means periodic blood tests, checking sodium, potassium, BUN, creatinine. Monitoring body weight is also really useful. Sudden weight gain can signal fluid reaccumulation. The frequency depends entirely on the patient, the cause, and how stable they are.
Are there any, potential pitfalls or complications to watch out for when treating ascites, especially with diuretics?
Yes, definitely things to be cautious about. Using diuretics too aggressively, especially loop diuretics like furosemide, can lead to problems. Dehydration, obviously. Low potassium levels, hypokalemia, are a big concern. Low potassium can sometimes lead to a metabolic state called alkalosis. And in patients who already have underlying liver disease, this alkalosis can actually worsen brain function, a serious condition called hepatic encephalopathy.
How does that happen?
It relates to ammonia metabolism. Alkalosis can shift ammonia in the body towards a form, NH3, that more readily crosses into the brain, causing neurological signs. So it's a delicate balance you need to get rid of the fluid, but not so aggressively that you cause other major problems. Careful monitoring and adjusting doses is key.
Wow. Okay, so wrapping up our deep dive today, it really feels like the big takeaway is that ascites itself is, well, it's a sign. It's a signal that something else, often something significant, is going on inside the body.
Exactly.
And really understanding the characteristics of that fluid alongside all the other clinical signs and tests is just absolutely crucial for figuring out that root cause and then, guiding the right treatment.
Couldn't have said it better. That analysis of the ascitic fluid itself is just such a powerful diagnostic tool. It provides a wealth of information about what's happening internally.
Thinking back, one thing that really struck me was that whole comparison between chyle and pseudochyle. The idea that something as simple as putting the fluid sample in the fridge to see if it separates, or using that Sudan stain for fat, it's just fascinating how those seemingly small details can give you such big diagnostic clues.
It really is. Little things matter.
Or even that point about urine in the abdomen, how it might not show glucose or protein right away if the rupture is really recent. It just reminds you that these bodily processes are dynamic. They change over time. You have to consider context.
Absolutely.
So for you listening, hopefully you now have a much deeper understanding of what ascites is, the surprisingly wide range of reasons it can develop, and the pretty detailed investigation that goes into figuring it all out.
And maybe it leads to a broader thought, doesn't it? How often do we maybe overlook seemingly minor symptoms, dismiss things as just a bit of discomfort when they might actually be important signals our bodies are trying to send us?
Yeah.
That fluid in ascites, we think of it as just this problematic excess stuff that needs removing. But really, it's this incredibly rich source of information. It highlights how intricately different body systems communicate, especially when something goes wrong. It makes you wonder, what other seemingly negative symptoms might actually hold really valuable clues about our health if we just knew how to read them?